you very much. As you've heard, I'm with the School of Public Health, and so by way of context, I'm going to talk a little bit about public health and what a public health approach offers. So then I'm going to talk about public health in Australia using the example of tobacco control, which is very familiar to me and will be familiar to many of you, and give you some food for thought about addressing the newer challenges that we face now in Australia in public health around dietary risk and obesity. So, very briefly, public health is about the organised measures that we take in society to prevent disease, promote health and prolong life. And so we do this in our population as a whole, or we can think about our populations as a community, a state, a nation, or perhaps a group of particular disadvantage within our community. So public health acts to promote health and protect people in the community where they live, where people learn, so at school, where people work and where people recreate. And really importantly, public health concerns itself with threats to health based on a population health analysis. So what is it that is generating the big burdens of disease for the population that we're interested in? So public health has delivered a lot. So when we look back at public health in the 20th century, these are the 10 successes of public health that the US Centres for Disease Control and Prevention identify. And they also have measured and determined that about 25 years of life expectancy has been added to people in the US, and you could extrapolate that to Australia, between 1900 and 1999 as a consequence of public health interventions. So, sanitation, these are all things that we take for granted. So, sanitation, safe drinking water, a safe food supply, eradication or virtual eradication of communicable diseases like TB and polio, low infant mortality, road safety laws, so not being allowed to drink, drive, speed, seat belts, etc. They're all things we take for granted and often think of as common sense in Australia. So historically, communicable diseases, malnutrition and injury were the leading global and also the local health burdens, but now we've had success in these areas, and now we face different problems. So both globally and within Australia, there's been an enormous rise in non-communicable diseases, or what we call NCDs. And there are 4 common behavioural risk factors that are associated with 4 disease clusters. And this makes up about 80% of the deaths from NCDs. So tobacco smoking, excess alcohol consumption, poor diet, which I'll be elaborating on, and inadequate physical activity are preventable risk factors which are driving enormous burdens in terms of cardiovascular disease, some cancers, most of the diabetes burden and chronic pulmonary disease. So if we look at what are the leading drivers of Australia's current burden of disease. So this is data from 2015. And what you can see here is that dietary risk is now the leading driver of the preventable burden of disease in Australia. And more than that, it's overtaken tobacco smoking, which was our leading preventable cause of burden of disease in Australia for a very long time. And this in part is due to our success in tobacco control, and it's also in part due to our relative failure around dietary risk and dietary overconsumption. So dietary risk is made up of a number of elements, and I'll elaborate on that. So firstly, what I'm going to do is talk about tobacco. And about tobacco control in Australia, and this is an area where we lead the world, and most of us now take this for granted, but this is something that has evolved over several decades and has come an awfully long way. So tobacco, of course, had an unparalleled impact on health. So tobacco-related disease, so lung cancer, for example, were epidemics of the 20th century. First, epidemiological science found the association, so they went looking to find the cause of lung cancer, which was thought to be tar on roads, and turned out to be smoking. And so epidemiological studies have shown us that when that smoking, long-term smoking, at first we thought it killed 1 in 2 long-term smokers, and we now know from the longitudinal studies that 2 in 3 long-term users of tobacco will experience a shortened lifespan as a consequence. So it's a unique product in this regard, so it's the only consumer product that's on the market which, when used exactly as the manufacturer intends, kills 2 in 3 long-term users. So we have unique controls around tobacco. So it's responsible for an awful lot still of burden, but nicotine is also addictive. This was demonstrated to us by science but denied by industry well into the 1990s. So we knew it was deadly, we knew it was addictive. It was being promoted heavily by manufacturers, and yet smoking was ubiquitous in Australia. So after the Second World War, about 80% of Australian men smoked, fewer women, and now we're at the point where only 15% of Australian men smoke. Amongst our school kids in the mid-80s, we had more than a third of 16 to 17-year-olds smoke, and 1 in 5 12 to 15-year-olds were smoking at that time. And in 2014, we were down to 10%, and we're at 3% of 12 to 15-year-olds. And when we go down, and that's you know, they're phenomenal changes over a few decades of concerted effort. It's not to say that smoking is no longer a problem in Australia, because of course there's more work to be done. We have unacceptably high rates of burden from smoking-related diseases amongst the very socio-economically disadvantaged, among people living with mental illness, and among Aboriginal and Torres Strait Islander people. And you might see efforts in tobacco control that are now focusing around these efforts to try to reduce those burdens. And of course we also now need to work out what to do, or we're in the process of designing a public health response to the emergent area of e-cigarettes. So how did we achieve what we achieved in tobacco? Well, taxation and pricing were and are our most powerful tool in tobacco control. So increasing the rate of tax for tobacco products, it has 2 effects. It allows government to reduce population consumption of tobacco. Young people and people on low incomes are very price sensitive, so we know the more the rate of cigarettes goes up, the more smoking rates come down, particularly amongst young people and lower income people. And it also increases government revenue, so it's an important source. It's a source of revenue for government. Some of that revenue goes into supporting the other measures around tobacco control. So as I've said, the evidence around the effectiveness of tax and pricing policies are overwhelming. The second really powerful tool that we have in our toolkit are public education campaigns. And so these are education campaigns that have been really well designed. They're proven to increase quitting and reduce smoking rates in both adults and young people. So these have a whole basis of, there are a whole lot of studies that have been done to both produce these and then evaluate these. We use behavioural science to understand what's likely to drive the behaviours that we're trying to generate, and then we follow through and see that they do. As well as promoting quitting, they also have an impact on the social norms around smoking behaviour, which we know are also important drivers, and build public support. And Australian campaigns have been exported all over the world. So advertising and sponsorship bans. So the promotion of tobacco obviously is going to encourage use and also glamorise what's in fact a deadly and addictive product, particularly with young people. So we've put a lot of controls around that in Australia. Smoke-free areas, of course, support for people quitting, so making sure that people have the support to change the behaviour that we're asking them to change, and then increasingly large health warnings and standardised packaging. So this has been a very hard-fought fight, and this has been an area, once again, where Australia has been a world leader. So, you know, we would argue that the intent of the pack and the imagery that's on the pack is glamorising smoking for young people, and our attempts around plain packaging really were twofold: to decrease the glamorisation of smoking for young people and discourage uptake, but then also to make make the health effects more prominent and a reminder for smokers every time they opened the pack. And of course they did exactly that, and also made an independent contribution to reducing smoking rates. So to sum up on tobacco, so we had a multifaceted approach. So we looked at price, we looked at promotion and product, and we created supportive environments that encouraged the behaviour that we wanted. And fundamentally, we've always been underpinned by a really solid evidence base. And tobacco isn't the only area of public health where we've had this sort of approach and where we've had success. So the way Australia's handled HIV and AIDS has been a public health oriented approach. Road safety is something that'll be familiar to all of you and something you'll do every day. Helmets, seatbelts, drink driving, speeding, they're all regulatory measures designed to protect health. The sort of approach we've taken to vaccination. So when we're talking about a comprehensive approach, we're talking about educating and informing and motivating individuals, but we're also critically talking about making changes to the physical and social environment, which we know are fundamental to the way people behave. We're also trying to generate small changes in individuals which accumulate across whole communities and yield public health gains. So, what of Australia's increasing dietary risk? So, as everybody knows, overweight and obesity has increasingly become a concern. So, more of our adults are now overweight or obese than the opposite. In some parts of the world, like Tonga, obesity rates are at 80 to 90%. And 1 in 4 Australian kids are now overweight and obese. And this happened quickly. So between the 80s and the 90s, overweight doubled and obesity tripled, and it's continued to move up. So of course there are lots of very serious health consequences and burdens to the community's health from overweight and obesity, and there are also substantial direct costs to the individuals themselves and also the community. So put very, very simplistically, overweight comes about when there's an energy balance, and obviously there are a whole lot of biological factors that are at play, but it's an imbalance between the energy in the food and drinks that we consume and the amount that is required to run our bodies and also the physical activity that we do. So one of the things that gets a lot of discussion and is certainly promoted very heavily by the food industry is the role of physical activity and sedentary behaviour in overweight and obesity, and its potential as a solution to obesity in Australia. So physical activity is certainly important when it comes to weight. It's very important when it comes to health as a whole. But when the people who do the work around, but the estimates that research in this space is producing tell us that physical activity contributes about 20% to the equation, and overconsumption, so dietary risk, contributes about 80%. So what we're talking about when we're talking about the Australian diet, so this is what the Australian dietary guidelines say the Australian diet should look like. So we should all be eating about 80% of the core foods, so fruit and veg, whole grain cereals, proteins, dairy, etc. And then we should only be, so our diet should consist of less than 20% of non-core foods, so we should be eating these occasionally and in small amounts. So non-core foods or discretionary foods is how we talk about them. Junk food and drinks is probably how people know about them. So the dietary guidelines tell them that they're not necessary. They're all the foods that are high in fat, sugar and salt, and they should be included sometimes and in small amounts, and for those who are physically active. So these are the foods we're talking about. I'm sure you all know exactly what they are, and I've just highlighted the ones that are high in sugar. So what are we actually eating in Australia? This is what the Australian diet actually looks like. So 60% from core foods, but we're getting way, way, way too much of our food, our energy from non-core or discretionary or junk foods. So 40%. So basically instead of eating them in small amounts occasionally, and that's how people talk about how they eat them, in fact we're eating them daily and we're eating them in large amounts. So as a population, we're getting 40% of our intake from non-core foods, and 2- and 3-year-olds in Australia are getting 30% of their daily intake from non-core foods. So you can see, so they're being consumed every day in large amounts, and unsurprisingly, Australians are overweight as a consequence. So this is one of the public health problems. So over-consuming junk foods and sugary drinks, and under-consuming core foods like fruit and veg is a driver of ill health. And so poor diet and resultant overweight and obesity are now the leading public health threats in Australia, and they're driving chronic disease. So how are we responding to what is now a public health problem? So medically, we're recognising it, we're responding to it, and we're treating it at an individual level. As health promoters, we've done some educative and community level interventions, mostly at a small scale and mostly without much success. What's our policy response look like? We have some voluntary codes, so we have some star warnings, and we have some voluntary codes around advertising, but there is very mixed compliance and arguably quite low compliance. And how are we handling this politically? Are we talking about this being the big burden on our health that we need to address? We're not. So really we're treating this largely as a matter of individual responsibility, or perhaps even a moral failing. So I'd argue we're overdue for a public health response. So this means a comprehensive suite of interventions. It means interventions driven by evidence and that are tested for effectiveness and then followed through and evaluated. It means addressing not only individual behaviour but also the social and environmental drivers of behaviour, and it includes policy and it includes large-scale and effective public education. So, turning to sugary drinks. So this is what we mean when we talk about sugary drinks. So it's all of the non-alcoholic water-based beverages with added sugar. So soft drinks, energy drinks, sports drinks, iced teas, etc., etc. So, sugar in the Australian diet. So the World Health Organisation recommends that we have not more than 10% of our energy intake from free sugars. So that's about 12 teaspoons a day, or preferably 5. And this is meant to make, this is the totality of added sugar in our diet. So if we go back to what contains the sugar, it's not just the sugary drinks, it's the biscuits, it's the cakes, it's the added sugar in the food supply. And more than half of Australians exceed this, and that's particularly the case amongst older children and amongst adolescents. And so these are people who are consuming a lot of sugar in their diet, and they're developing a palate for sugar, and that's going to take them through life. So beverages in particular contribute over half of the free sugar in the Australian diet. And 19% of the sugar in the Australian diet comes from soft drinks, energy drinks and sports drinks alone. And that's because a single can of soft drink contains 10 teaspoons of sugar. So you can see it's already right up there. And a 600ml bottle of soft drink, which would be a standard measure for lots of people, is 16 teaspoons alone. And we know that lots of people are drinking a lot of these drinks all the time. And it's particularly, these are average rates, and these rates are far higher in young people, in adolescents and young adults. So this is why we focus on sugary drinks. So they add a lot of extra sugar into a diet that's got too much sugar. That brings calories. The calories that they bring are empty calories. So unlike an iced coffee, for example, it doesn't bring protein, it doesn't bring any food with it, so there's no vitamins or protein or fibre that might come along with a sugar-sweetened beverage. Interestingly, they don't make people feel full. So the body doesn't register a sugary drink the way it might register a donut. So there's no reduction or compensation that the body makes around other food or drinks as a consequence of having the sugary drinks. There's some evidence that it appears to stimulate appetite, and they're also often contain caffeine, and they're the main source of caffeine for Australian kids. So then what about the health effects? So The other reason that we focus on sugary drinks in particular within the Australian diet, or as public health people who are interested in policy, is because the evidence of health effects from sugary drinks is so clear. So systematic reviews have found direct causal links between sugary drink consumption and excess energy intake, which causes and weight gain and obesity. And importantly also, there are studies that show that when kids reduce their soft drink consumption, their weight gets better as well. So studies have also shown us there's a really clear indication of increased risk of type 2 diabetes. So someone who has one can only of soft drink a day is a 25% increase of diabetes compared to someone who hardly drinks them at all. There's emergent evidence around cardiovascular disease risk factors in both adults and adolescents, and this is in people with healthy weight. And there's just been some media around a new study around stroke. And of course, they're the main dietary cause of dental caries and dental erosion. So on average, about half of Australian kids, or kids and adolescents 2 to 16, are drinking a sugary drink every day, and 31% of adults also are having one of these every day. So these are the averages. Young children are drinking cordial and fruit juice drinks. So the 2-year-olds are drinking more cordial and fruit juice drinks. The adolescents are drinking energy drinks, sports drinks and soft drinks. And so the peak consumption is amongst the adolescents, particularly adolescent males and young adult males, and then it tapers off as people get older. And some of the work that we've been doing in my group at SAHMRI has been going into this in a bit more detail. And so it's not uncommon at all for young adults to be routinely drinking a couple of litres of soft drink every day. And even some people have been telling us that every day they would consume up to 7 cans of energy drink just as part of their normal routine. So as you can see, that's putting a phenomenal amount of unneeded sugar into those people's diet. So increasingly, sugary drinks are attracting international attention, and one of the policy responses that is of greatest interest is a sugar tax, or a price signal on these drinks, or as Australian health groups who are calling for it are calling it a health levy. So this would be a levy with some of the funds diverted to pay for other obesity prevention initiatives, such as public education campaigns or programs with kids around balanced diets. So the World Health Organisation is recommending government use these and concludes that there's reasonable and increasing evidence that a price increase of around 20% would result in a proportionate reduction in consumption. So what evidence do we have around this strategy in Australia? So we know fundamentally that price influences consumption. So this is a sort of first rule of economics, but we also know it applies for sugary drinks. We know that young people and people on low income are the most price sensitive, or what we call price elastic. So they're most likely to reduce consumption in response to a levy. They're also most likely to yield the gains from doing so. So Australian modelling that was done in 2016 for a 20% increase in tax projected that we would expect to see a reduction in consumption around 12.6%. It also extrapolated to reductions in obesity amongst men and women over 25 years, and said that we would see several thousand fewer cases of diabetes, ischemic heart disease, stroke, and even fewer deaths. So this is just from putting a 20% increase on the price of sugary drinks. So further to that, it's a policy strategy that would generate a lot of revenue in government, some of which could be used for obesity prevention, and also critically save a lot in healthcare. So what does the public think about the idea? So work that we've done at SAHMRI tells us that when we talk about adding a tax to sugary drinks, probably around half of the community support that. So The concerns that people raise are, well, they're obvious. So none of us really like the idea of paying more for anything, of course. Most of us aren't that concerned about other people paying more if we don't have to do it ourselves. Lots of people argue or think that all we need is information. And while we know that information is really important for people's decision making and behaviour, it's simply not enough. So 99 or 99.9% of the behaviours that we undertake every day are basically habitual. So we need things that influence our behaviour in our environment. And people also often raise the question of fairness and equity, and these are important questions which I'll move on to. So when others have done work around this space, we found that we've got quite high levels of public support if it's a health levy on sugary drinks. So if some of the money were used to reduce the cost of healthy food, like fruit and vegetables, then support's very high, as you can see, and support's far higher again if some of the money is used to fund childhood obesity prevention and to encourage children's sport. And so this is exactly what's happened in tobacco control. So a big price increase was put on cigarettes, a little bit of the money was used for other tobacco control interventions, and most of the rest of it goes into consolidated revenue. So internationally, the data that we're seeing around this initiative has been really promising. So Mexico, for example, and Mexico was the highest consumer of sugary drinks in the world. Mexico has very high rates of obesity and also stunting. So they have malnutrition combined with obesity, which is something that's becoming increasingly prevalent. So they added a peso per litre to their sugary drinks in 2014, and within about 11 months they reported and published in the British Medical Journal findings of a 12% reduced consumption in sugary drinks, and they also found that water had gone up. So they'd shifted from the behaviour they were trying to, nudged from the behaviour they were trying to influence to the behaviour that they wanted. And the biggest changes were observed in low-income households. So the biggest gains were reaped where the disadvantage was greatest and where the health burden is highest as well. So France also has introduced a levy on sugary drinks, and the US, Berkeley and California have done it, and both of those jurisdictions have reported declines in consumption. And France has also noted the change amongst a bigger change amongst the highest consumers. So Chile's done it as well, but I haven't seen data from there yet. And the UK are going to introduce one in 2018. They've done modelling like Australia's done. The results look similar, and they're using some of their money to fund obesity prevention and promote physical activity and balanced diets in children. So internationally, I think the results are looking very promising. So we would never argue that a health levy on sugary drinks would be an isolated intervention. That's not what we're saying at all. So there are other initiatives that are happening, sometimes in Australia and sometimes around the world, that are part of this sort of comprehensive approach. So Chile, for example, have done quite a suite of interventions. So they're also restricting children's exposure to marketing, and they've put warning labels on their sugary drinks. So the data's yet to come out around the effectiveness of those interventions, and looking at the potential of warning labels in sugary drinks is one of the things that we're working on in my team at SAHMRI as well. So within Australia, Alfred Health have done some experimental work around restricting sales and health services. People often say we shouldn't have these things available for sale, or we certainly shouldn't make these the main things available for sale in health services, and their results have been very promising. They've shown no drop in revenue for the retailer, which is critical when you're trying to introduce these sorts of interventions, but they've seen a shift from sugary drinks to a shift down in purchase of sugary drinks and a shift up in purchase of healthy drinks. And then we've got the tobacco-style public education campaigns starting to be produced as well. So about, I think, at least two Australian states now, Western Australia and Victoria, have been running these sort of doctor's eye view mass media campaigns that we've been doing in tobacco control for a long time. And these states have been able to show behaviour change specific to what they're after, an absence of unintended consequences around raising stigma around overweight and obesity, and also the changes haven't been observed here in South Australia, and we acted as a control state for those other states. So just to refresh, And to summarise, this is what's worked in tobacco. So a multifaceted approach using taxation, regulation of promotion and product, intervening to create supportive environments and quality public education and behavioural support. It's been underpinned by a really strong commitment to evidence, so epidemiology, research and evaluation. This has been really important in tobacco for two reasons. Firstly, we need to know if what we're doing works and why, and if something doesn't work, then we need to discontinue it. But it's also because we're in a space where we're where we're heavily contested by industry, and often there's litigation, as there was with plain packaging, and there also was around smoke-free environments. So having a very solid base of evidence is critically important. And so this is what a multifaceted public health approach would look like in terms of reducing Australia's dietary risk. And reducing overconsumption, and in the first instance looking at reducing overconsumption of sugary drinks. So taxation, so a 20% levy on sugary drinks linked to health interventions which would also support the behaviours that we're hoping for. We can consider looking at promotion and product, so restricting children's exposure to advertising and promotion, which is ubiquitous at the moment. Also packaging with effective labelling, so consumers have a better understanding of what they're buying, what it contains, and even exploring warnings. And as I said, that's one of the things that's a research area of interest for me. Supportive environments in this space, so that would look like restricting sales in schools, hospitals and some youth settings, for example. So in Victoria, the YMCA no longer sells sugary drinks. And then education and behaviour support, so helping people to understand. People often have a very superficial level of understanding about health, and understandably so, but helping people to genuinely sort of understand and have a greater insight into the behaviours that are impacting on their health. So how much sugar's in sugary drinks, what the potential harms are, and then motivating reduced consumption. And then also other interventions in schools and communities. So we've done all of this in tobacco control, and it's all been part of our comprehensive approach. And then once again, absolutely underpinned by evidence about what works and what doesn't work and why. So in conclusion, dietary risk and overweight and obesity are major public health threats now, and they're driving a huge range of chronic disease. And I would argue that what we need now is a public health response. So public health's more than just about common sense, it's more than just educating people and letting them take personal and parental responsibility, and when it doesn't work, blaming people for that. It's about policy and regulation which influence the environment and behaviour. They're fundamental, and they always have been in every element of every area of public health where we've succeeded. So opponents will often say that we're impinging on individual freedoms, but this is part of facing the reality about how our behaviours occur, and it's also about recognising that promoting products and having product use that's ubiquitous has an impact on our health. So I'd also argue that continuing to treat poor diet and overweight and obesity as moral failings or failings of parenting rather than as the public health priority that they are will do nothing to arrest the burden of NCDs that we now face. So we have a strong record of success in public health in tobacco control, and I think expanding this public health approach to sugary drinks shows enormous promise. So a sugary drink tax, I would argue, would be a good first step in reducing consumption, raising revenue, and it's shown to be internationally successful. So thank you.
Thank you, Caroline, for a really stimulating lecture. I'd now like to invite the audience for any questions, and if you could introduce yourself when you ask your question, that'd be terrific.
Thank you. Thanks, Caroline. I enjoyed that. I'm George Kiroff. I'm a surgeon. Actually, I have an interest in bariatric surgery, so this resonates with me. And I think the evidence, the nexus between epidemiology, biochemistry, physiology, and explosion in obesity that you've demonstrated is irrefutable.
Yeah.
I think anyone with a brain would accept that, except the industry, of course,
Yep.
tries to proselytise and bamboozle us with pseudo-evidence. But I'd like you to think outside the square a little bit. You're trying to change the behaviour of the consumers out there in society directly by imposing arguably a modest impost and a modest increase in the price of the end product. Instead, I think that we could do things with tax that modify the behaviour of the industry that produces the product and get them to change the behaviour of the consumer secondarily. And I put to you that you showed them lovely glamorous images of bikini-clad models or unclad, and we know our industry is really good. The Madison Avenue types are really good at selling us products. They're really good at it. Let them do it. Let them do your work for you. And I'll put to you how you can do this. Instead of putting the impost on the product, it beggars belief that in 2017 we've got an established poison, sucrose, we're adding it to drinks, we're selling it to people, and we give the people that produce this a tax deduction for the promotional budget. Okay? All of their promotion, all of their advertising is tax deductible. It appears to line their accounts. Furthermore, we know from the breakdown of the products they sell how much revenue they generate from sugar-added products and from non-sugar-added products. I suggest that instead of taxing the product and therefore hitting the consumer indiscriminately, do away with the tax deductibility of the promotional budget of people that add more than 5 grams per cent of sugar to their products. And you can check their revenue on the other side of the ledger, and to the extent where they sell products that do not contain sugar, give them a rebate. Indeed, do even better than that. Instead of not giving them a deduction, impose a 100% tax on the extent that they spend money promoting the products. This flip side now is that people like Coca-Cola Amateur will be inclined to sell products that don't contain sugar. They'll use their advertising men to glamorise, Brussels sprouts, for example, which are not glamorous at the moment, and perhaps achieve your ends without actually directly imposing that cost on the consumer. You could argue that there should be no net change in the actual cost of products that consumers consume, because if the advertising is not spent there but spent somewhere else, there won't be any cost to pass on to the consumer, if you know what I mean. I'll leave that thought with you.
Thank you. That's a very interesting idea.
I think Jennifer Hawkins is glamorising Mount Franklin.
Yeah, and I mean, it's an interesting idea. In tobacco, there have been some sort of financial prosecutions of the industry, and really it's all about the incentives and what the incentives translate into in terms of the behaviour of the consumer. Interestingly, in the UK, where they've foreshadowed a sugary drink tax, there's been quite a lot of reformulation. So the industry doesn't reformulate when there's no threat, but when there's an imminent threat, then there's a lot of reformulation, a lot of sugar coming out of products in the UK that we haven't seen here, which is great. So that's a great outcome. Yeah, that's a great outcome. Yeah, but by and large, the industry is there to sell as much of its product as it can, to return to their shareholders, and the consequences for health are the responsibility and a problem for the community and for the government. Yeah.
My name's Silvio Tarka. I'll try and keep my question succinct. Legislatively, can the states introduce a tax on sugary drinks, or does that need to be done at the federal level? And if it were done at the state level, how much revenue would a 20% tax raise in South Australia? And do you think the South Australian government would pursue that, perhaps as a leader of states, as it has done with the 10% deposit scheme on bottles, which obviously the Coca-Cola and Pepsi strongly oppose?
Yeah, so I believe it would have to be done as a federal exercise. There has been some people have raised the 10% levy, the 10% container deposit scheme as an idea, so double that in South Australia, and you'll have that same effect. I mean, industry fight the container deposit scheme very hard and have done in other jurisdictions. So my understanding, it would need to be done at a federal level. So the projected revenue at a federal level, I think, was something like 400 million. So the state equivalent of that would relate to the consumption. So you'd start at about 8%, but you'd have to model it properly around the size of the population and the behaviour of the population. But yeah, people have looked at trying to do it at a state level, and I think interestingly in South Australia, some people think we have a better capacity here to do make some of the regulatory changes around food that we might not have in other jurisdictions where there are more jobs in food manufacturing. So it might be more politically important, because I mean all of these things, obviously, anything that's legislated is a political decision and has to be made by the elected officials who are concerned about more understandably and appropriately than health.
We've got a higher level of overweight and obesity.
Yeah, we do, and it's a function of so overweight and obesity relates, as does smoking, to socioeconomic advantage or disadvantage, and age as well. So often it's not that South Australia is unhealthier per se; it's just that the demographics of our population are slightly different.
Thank you very much for your presentation. My name is Simone Pickering. I'm actually a dietitian and I'm doing nutrition research and diabetes in vulnerable population groups over at SAHMRI. I will make a point, I'm quite interested to understand a bit more about possible pressure we could put on the food system, given that that's kind of part of the approach focused with tobacco control. But my question is around, I think, the behavioural aspects, and I think creating supportive environments, because understanding the behaviour around food choice and dietary self-care and the behaviours that are integral in that, and the fact that we don't eat alone, we eat in social contexts, we eat with friends, with peers, when we go out to have fun, to celebrate. I'm interested to understand a bit more around, I guess, two aspects. Are there supportive environments that could be created to facilitate a reduction of sugary drinks in those sort of contexts, and also to understand a bit more about with the tobacco, you were talking about the behaviours that were sort of targeted to push people away from that. What kind of behaviours might you be focusing on in terms of why people eat what they eat and drink what they drink that could help support that? I'm not sure we can answer
Yeah,
that.
I think so firstly, to supportive environments, I think supportive environments are incredibly important, and what we want to do really is to make a healthy choice an easy and a default choice, and at the moment it's not. A healthy choice is kind of a conscious and more difficult choice than going to whatever food supplier is in whatever environment you're in. And our social, what psychologists call social norms, or behavioural scientists refer to as social norms, around the way we eat and what we eat are completely different as well. So if you're in a group of people and everyone's drinking soft drink 4 times a day and you've got it in your house, then that has an enormous influence on the extent to which you think that is something that is routine and that you do all the time. And so there are lots of studies that tell us what the things are that drive any behaviour, including soft drink consumption, and its price and its taste and its availability at workplace or availability at school and availability in the home, and parental role modelling and what people think is what's normal in your social group. So supportive environments would be looking at things like what's in the vending machine at the workplace. Is it a sea of sugary drinks, or are 2/3 of the is 2/3 of what's available, or even better, not sugar-added drinks. It's about not having these drinks available for sale in schools, and then it's also about the sort of policy and regulatory environment. And I mean, promotion is incredibly important as well. So the extent to which we as adults, and then kids who have a much less developed sort of kind of critical media literacy are inundated with ads for these sorts of foods and beverages all the time is really important. And then the second point was about the behaviours that we're trying to change. So in tobacco control, we look to, we use models from behavioural science, so we look to change sort of cognitive or thoughts or what people know and understand rationally about things, and we know that most people could tell you that smoking's bad for you or smoking's a health hazard, but levels of understanding around a raft of different diseases really weren't there, and when we ran campaigns and put warnings on packs, they changed a lot. So sort of information and awareness, social norms about what everybody else does, but then also intentions around behaviour change are really important in terms of driving actual attempts to change behaviour. So smoking's a bit different because it's really, smoking, nicotine is incredibly addictive. And it's, you're either a smoker or you're not a smoker, basically, is how it works out. So that's a different behaviour, whereas with sugary drinks, we're trying to take it from multiple times a day, every day, back to where we probably were 30 years ago, where it was something people had, as a treat every now and then. So, but fundamentally it's about increasing people's sort of understanding about what's going on, and then driving the drivers of behaviour, which are around motivation to change and intention to change, and then creating and making them aware that it's something that needs to be attended to now. So we've all got behaviours that we plan to change in the future, and no behaviour changes until it's on today's agenda or tomorrow's agenda. So it's about all of those things, and that's what we try to do through our campaigns, and that's what we test before we put them in the market, and then test once they're in the market. Yeah.
Hi, thanks Caroline. I'm Rebecca going from Nutrition at UDSA. I guess you mentioned that disadvantaged groups tend to be price sensitive, but there's also another thought thinking that there is a degree of price inelasticity in these groups, and I guess you also mentioned that disadvantaged groups haven't fully benefited from the multifaceted approach from tobacco control. So I guess just your thoughts on some lessons that we can learn from the tobacco experience to sort of overcome or sidestep that sort of potential burden of bringing on disadvantaged groups.
And by and large, with smoking, the majority of people who smoke, particularly in recent decades, sort of blue collar type groups. That's where the big population lives. So, I mean, there are some very disadvantaged groups that have very high smoking prevalence, but by and large, most of our strategies have been targeted around the main body of smokers, which is, blue collar people, and they have actually shifted the whole curve along. So mental health has been an issue, and partly that's been because for people who went into mental health residential facilities, if they didn't go in as smoker, they certainly came out a smoker. So we've done work, and the state's done work changing that environment, and rates are higher amongst Aboriginal and Torres Strait Islanders, as our sugary drink consumption is highest also amongst Aboriginal and Torres Strait Islander, and that's about good quality interventions that are community-led and are well-funded, and that's exactly what's going on now in tobacco control. And there have been some efforts around that. There are actually also some emergent areas around that in sugary drinks. So, I mean, I think, it's an issue, and it's a serious issue, and you put the price of something up, and a lot of people will stop using that product or use less of it, and for the people who don't, they bear a higher burden, and that's definitely something we've thought about a lot. We attend to very carefully in tobacco control. Sugary drinks they're not nicotine, so they're far more, it's a behaviour that arguably is much easier to change than smoking, and what we're looking for is a reduction in consumption. And I suppose we're seeing, countries that are far less affluent than Australia, like Mexico, do this work and produce results that show that overall these things are working, and they're working better with those groups. So I don't think we've got it, we're not perfect in that space, and it's a concern for people in the field, but I think the balance by and large is moving in the right direction. And we know that if we drop the price of these things, smoking rates go up, and 2 in 3 people will eventually die. So that's not a good, it's a pretty serious sort of consequence as well. Yeah.
Final question.
Thank you, Professor. I've been living in Australia for 14 years after you put the ban of tobacco, and then we feel the change was amazing. My name is Miguel. I'm a student of environmental policy management at Adelaide. Why not tax sugar as a whole, as a commodity, or because people can transfer to chocolates and cordials, and then we have a gap of consumers?
Yeah, I think that's an interesting question, and it's a question that often comes up. I think the reason that health agencies are focused around sugary drinks in particular is because the evidence is so clear around harm. So by and large, people for the international jurisdictions, people won't shift to cordial. Well, they shouldn't shift to cordial because that would be part of what would be captured. And by and large, people don't shift between beverages and foods. So they don't tend to swap their sugar from a sugary drink into sugar from chocolate. So but it's an interesting question, and it's one that, gets debated, and the UK, I believe, is doing sugar as a whole. Yeah.
Well, the last act that I need to do this evening as MC is to again thank Caroline for a stimulating and thought-provoking lecture, and give her this non-sugar sweetened beverage from the discretionary
alcohol,
group
right?
on behalf of Professor.
Thank you.
So thank you, Caroline.